Hello, thank you so much for having me. So again, my name is Leah Gordon. I am a nurse practitioner at Mass General. I work in radiation oncology. My career in nursing has been 14 years, and most of it has been in oncology. In 2017, I received my doctorate, and my focus was in nursing education, and I focused on cultural competence, or students' perceptions of the cultural competence in their nursing education. So this has been cultural competence, which I actually think, is a very good word to use, sometimes a little of an aversion word for people, but cultural competence I think is very important in healthcare. In oncology where I work, there's lots of disparities, and so this has always been on my radar, not only as a nurse, but as a person of color in this country. And then intersectionality is what we're going to talk about today, and it's sort of a newer buzzword that's in the whole sphere of cultural competence, but I'm going to sort of talk to you about what I know about intersectionality, but I'm also going to talk about my personal view of intersectionality. And then I want to also touch upon, whoops, this is the mic. I also want to touch upon, these following things. We're going to talk about race and how that leads the discussion, or how I think it's important for it to lead the discussion, why we need to acknowledge race and race-related issues. And this really ties into that Globe piece that was written back in December 2017. I want to talk about culture and spheres, and this has to do with a little bit about the intersectionality. And I want to talk about race, ethnicity, and beyond. Healthcare as a culture itself. I think there's some things that we need to recognize and talk about with as it relates to our culture in healthcare, and then how our healthcare culture intersects with other cultures. And then can we truly ever be culturally competent? Couple of things as I go through this presentation. I encourage you to ask questions as I go along. We're also going to have a breakout session and sort of reconvene and come back and talk about some of the things that we learned and want to share with each other along the way. So the first thing I want to do is make sure that people understand the difference between race, ethnicity, and culture. Race are the biological categories based on inborn biological markers. Ethnicity commonly refers to heritage that's shared by a particular group with similar history, language, ritual, and preferences. And then culture is a learned pattern of behavior, learned and transmitted within families and other social organizations, that's acquired over time, and it includes beliefs, attitudes, values, customs, norms, taboo, art, and ways of life that are acceptable to that community of individuals. Culture is shared by the majority of the group and includes individualized worldviews, guides decision-making, and facilitates its self-worth and self-esteem. So I think race really needs to lead the discussion when we're talking about cultural competence. When I look at this, I sort of look at this big umbrella of, we have these issues of racial dynamic that exists in this country that are certainly in the forefront, I would say, over the last decade with an African-American president, and now with our new leadership and some of the divisive nature of what's going on in the country. And although I think it's important to talk about LGBTQ issues, issues within the Black community, issues within subsets of communities. So like, for example, if we're talking about Latinos, we have people who are Puerto Rican, who are Dominican, Ecuadorian, Panamanian. There are those subsets under that group, but if we're not talking about race, if we're not dialoguing about race, we're not really getting to the full nitty-gritty of what keeps us apart in this country, or the sensitive subjects that we need to talk about that prevent us from actually really taking that deep dive into really trying to be as culturally competent as possible. So, one of the things that the Courageous Conversation folks talked about is this piece that was done in the Boston Globe about Racism, Image, and Reality here in Boston. I don't know if did anybody have a chance to read any of this at all back in 2017? I know the Courageous Conversation folks did, but did anybody else? So I really want to encourage you to take a look at this, because one of the things I want to mention is that there were 11 takeaways from the Spotlight series, and I'm just going to touch upon those really quickly. And they talk about, this is what the Spotlight series talked about, and it was 7 articles. If you have the time, I would encourage you to read it. And they talk about Boston's reality of having sort of a racist, or I shouldn't say sort of, having a racist reputation, Black families being poorer than other communities of color here in Boston. Greater Boston's is whiter than most other major metropolitan areas. They talked about discrimination being real, enrollment of Black students into college, and one of the big ones that was truly important to me was about the healthcare segregation that exists here in our city. And obviously this is the Boston Globe. There's a lot of talk about fake media and real media, but in these series, they actually substantiate everything they say with statistical data. And so I think it's really important, especially here as New Englanders, as people who live in Massachusetts, we're here in Milton, not too far from Boston, just to keep our finger on the pulse and try and take a look at these articles if you have an opportunity. The other sort of screenshot there is from the New York Times, and why is race such a hard topic to talk about? So one of the political writers from the New York Times, Matt Bai, wrote a piece called "Race is Still Too Hot to Touch." And he examined national culture. And I'm just gonna read this because I think it's important in terms of some of the complexities of why these dialogues are so complicated for people to have. So he talks about familiar patterns in American life, in which anyone who even tries to talk about race or race-related issues are sort of either there's public outrage if you have these conversations, there's humiliation associated with it. And I think we hoped that a lot you might hear in racial dialogue, people will talk about this post-racial society, and we talk about this because Obama was our president, but we're not in this post-racial society. We're truly in this time where we really need to confront issues of race and racism to move the dialogue forward. So he talks about the fact that, we had a Black president, and that would somehow make the subject less volatile, less sensitive, in the way JFK, when he became president, sort of quelled the tension between American Catholics and Protestants. But Mr. Obama's presence, along with the delivery of delivering us from racial dialogue, made it even more complicated. And I would say that it really made it more complicated for every culture, every race in this country. And in some ways, Obama's election seemed to have further confused the conversation. Some white conservatives didn't really feel like they wanted to have this conversation, wanted to take it off the table, while some civil rights groups were struggling with the question of how to fight racism in a nation led by a Black president. So with regards to healthcare, as we know, we struggle with our past history with race and racism here in this country. The last decade has brought this complicated conversation to the forefront. And in healthcare, I sort of ask, how do we use this in the context of healthcare? And what I think is important is that we need to look at this like any other public health crisis. So, fall risks are an issue. Cultural competence needs to be discussed. The opioid crisis is a problem. Cultural competence still needs to be discussed. And, I look at the issues around race, racism, and issues related to cultural competence as a public health issue that needs to be addressed. So just to kind of review some of the healthcare disparities that exist in this country, I just got this off of the U.S. Department of Health and Human Service Office of Minority Health website. I'm not going to go through every detail, but I just want to make sure that people are aware that when we talk about Black American health, the death rate for Black Americans is generally higher than it is from our white counterparts as it relates to diagnoses into heart disease, stroke, cancer, asthma, pneumonia, diabetes, HIV/AIDS, and homicide. Our Native American and Native Alaskan individuals frequently contend with issues of health that prevent them from health. A lot of it has to do with where they're geographically located and how they can access healthcare systems. There's barriers related to sewage disposal, low income, the infant death rate is higher. They're twice as likely to have diabetes. They're disproportionately high rates from unintentional injuries and suicide. Asian Americans, one interesting fact about Asian Americans here in this country are Asian American women tend to live longer than any other cultural group here in our country. So we talk about how healthcare needs to sort of move with the fact that our population is aging. This is a group here that really needs some attention to that. So there's also language and cultural barriers, lack of health insurance. They're at risk for the, heart disease, stroke, unintentional injuries, diabetes, and high prevalence of COPD, hepatitis, tuberculosis, and liver disease. When we talk about our Hispanic or Latinx groups here in this country, they're shaped by factors related to language barriers, cultural barriers, lack of access to preventative care. As a nurse practitioner, we're trained in the preventative care model. So as much as the healthcare system wants us to work on preventative care, we're still so busy trying to keep up with people and the diagnoses that they have that it's hard to actually work as a preventative care provider. So it's certainly something that's very concerning with this particular group. Some of the leading causes of diseases in the Hispanic population are related to heart disease, cancer, unintentional injuries like accidents, stroke, diabetes, and there's a higher rate of obesity, which is a public health crisis in this country. Native Hawaiians and Pacific Islanders also have higher rates of smoking, alcohol consumption, and obesity, and high rates of cancer, heart disease, unintentional injuries, stroke, and diabetes. So I just want to talk a little bit about some of the mistrust of at least two communities that I've touched upon here. The first being African Americans, and this is something that obviously resonates with me as a woman of color, a Black woman of color. Black Americans fear exploitation by medical profession, and it dates back, I think some people know about Tuskegee. Is anybody familiar with Tuskegee? But it actually dates back to this antebellum period. And the antebellum period is considered the time right before and right after the Civil War. And people were, this group particularly was subject to medical experimentation that they were not agreeable to. So at that time, we didn't have informed consent. And because Black Americans at that time were considered property, they would just be offered up for medical experimentation. And again, that's what it says right there. Slaves were considered property, and states denied them legal rights to, and so they were then just volunteered up for medical experimentation. Has anybody heard of Dr. Sims? Because he was in the news recently. In 2017, in New York, Central Park, there was a figure of Dr. Sims who's pictured over here. And then this woman here is a slave, and she's known as Lucy Lucy. So Dr. Sims is considered a pioneer in gynecologic information, I will say. So he performed numerous procedures on slave women without anesthesia, and learned a lot about how certain gynecologic conditions could be addressed and treated. But when he would do these procedures, he would not provide the slave participants or unwilling participants any anesthesia or any antibiotic. And so once he perfected the procedures he was doing, he would then offer them to white individuals, and he would offer them antibiotics and anesthesia. So this is something that I think broadly people are not aware of, but individuals in Black culture are aware of. And it's something we need to keep in mind as individuals who work in healthcare. The Immortal Life of Henrietta Lacks. So one really cool thing I just found out from Cheryl is that you guys have a cultural competence book club here, and this has actually been a book that you guys have read in this club. I think it's really important for people to know, or even if you're not part of the book club, I would encourage you to read this book. This is a really amazing story. Oprah, when Oprah gets her hands on something, it's really popular. Oprah actually played Henrietta Lacks's daughter in this story. And what's interesting about Henrietta Lacks is there are these cells that we use. We actually still use them in oncologic research called the HeLa cells. And HeLa comes from Henrietta Lacks. And we use these cells to do research on cancer diseases. And these cells were obtained from Mrs. Lacks while she was herself going through, I believe she had a cervical cancer. These cells were obtained from her without permission, and then these cells continued to grow. So the interesting part about this story is Henrietta Lacks's children, who were not formally educated, really believed that those cells were their mother. And essentially they are, but for them it was culturally, you have our mother in a lab. You have her held hostage. These cells are in a lab, and you're experimenting on our mother year after year after year after year. And the daughter, who's portrayed by Oprah, who also suffers from mental illness, was really, really troubled, very troubled by this. I think Oprah's movie was great, but I actually think reading the book will give you a greater context of how traumatizing this was to Henrietta Lacks's family, to think about the fact that their mother, who was treated at Johns Hopkins, which at that time had a Black ward and a white ward, suffered really poorly from her cancer treatment, maybe different from others, although they don't explore that very much in the book, passed away, traumatic to the family, obviously, and then her cells somehow are living. And so how do families contextualize that? And does that create an aversion for people of color, specifically Black Americans, to be part of research studies, to be willing participants in medical exploration that may actually be helpful for them at some point down the line, but is hard to contextualize when it's being done, again, without permission. And then the other thing that I think that's really cool about this book is it sort of has a personal story paralleled with a scientific story. So I think it's great for people who work in healthcare, no matter what area in healthcare, to read, because it resonates. It will resonate with you. And then Tuskegee, as we know, it's probably one of the most sentinel events in terms of medical research. It's one of the reasons why informed consents came about. There are a couple of other sentinel events that were wrongly performed against other groups. One of them is the Holocaust. There were a lot of horrible things that happened during the Holocaust that we learned about medical science, and we know about medical science today. We use in medical science. But that was a sentinel episode, and the Tuskegee case was a sentinel episode. So if you aren't familiar with Tuskegee, it's basically, it was a study that the government conducted between 1932 and 1972, including 399 Black men, where they were deliberately affected with syphilis, or I shouldn't say they were affected with syphilis, they were deliberately denied treatment for syphilis. So they had syphilis, and the way we know how syphilis manifests, so if you're a healthcare professional at any level and you read in your textbook what syphilis does to the human body, the human brain, we learned that from this study. We learned that because 399 men were denied treatment for a syphilis disorder that could have been treated with antibiotic. And so again, this was a governmental study, and in 1997, President Clinton actually formally apologized to individuals who were treated in the syphilis study, and I think that acknowledgement was huge, not only from a healthcare perspective, but was huge in the Black community, because somebody was actually saying, we did something wrong, we hurt you, and we apologize. Let's see. So some of the barriers with regards to Hispanic and Latino population, a lot of this is related to linguistic barriers, lack of trained interpreters, and not having a lot of bilingual staff, using family members. How often do we go to trainings where we are told do not use a family member as the interpreter, but they come with their son, their daughter, their sister, their brother who speaks really good English, and so we're in a pinch, we don't have enough people in interpreter services, and we use the family member to interpret medical information that we're sharing with patients that can be really heavy and burdensome for that individual who's translating to share with their family member. And so that creates a boundary there. Many of the people in this particular population will use their own cultural medications and might deny or decline some of the pharmaceutical prescriptions that we provide as providers. Recent immigrants face issues related to their immigration status. As many of you know, the 2020 census is going to be coming out, and I think it was just blocked by some court that we cannot ask immigration status on the 2020 census, but I don't think it's like firmed up. So if we ask the question about immigration status on the 2020 census, that is going to result in many people choosing not to answer the census, which will impact us broadly in this country, from a healthcare perspective to a senior life perspective, to a child care perspective, to budgets that are delineated in the government for certain things that are important for us, because we won't have accurate numbers and accurate details of who's here in this country and how our funds need to be delineated so everybody gets what they need. So if this immigration status does not fully get resolved, we're going to see what the census has done every 10 years. We're going to see dramatic changes in the numbers that aren't going to make any sense at all, that will provide our government to work off of and maybe impact us in like really negative ways. And then in this group, there may be individuals who practice folklore healing or traditional healing practices, and that can be somewhat challenging in traditional American healthcare settings. So one of the things that I'm working on personally is trying to merge traditional healing practices with healthcare, with traditional healthcare practices. So again, somebody might refuse, in this culture, might refuse a prescription that I've offered as a nurse practitioner because they have some traditional tea or tincture at home that they'd prefer to use for their flu rather than a Tamiflu that I think might be beneficial for them. So I like to look at culture in spheres, and they call this intersectionality. This is what intersectionality looks like to me, but these are all overlapping spheres, and in the center is you and who you are. So an individual has a gender, they have their race, their ethnicity, their sex, their social economic status, their age, their ability, their sexuality. But further in these spheres, we have cultural connections with our family, with our church, with the schools we go to, with the hospital we work at, with the business that we're involved in. So these spheres basically are showing us how complex we are as humans, but how complex it is for healthcare systems to interact with all these complexities of the individuals who walk through our door every day. So intersectionality was first coined by Kimberly Crenshaw in 1989. She is an African-American woman who is a feminist, and so she used this term back in '89, and it seems to be coming up, especially as we talk about cultural competence. It's a term that merges health equity and social justice. It focuses on power dynamics. It moves beyond individual factors such as biology, socioeconomic, and sex and gender, but it really breaks down more of the core of who a person is and how they walk in the world. So as it sits there, it addresses not just the who, but the why and the how. And it can inform change on very broad levels. We're looking at all of the parts that make up the whole in intersectionality, and two of the major aims is to bring attention to the important differences in population groups that are often portrayed relatively as homogeneous, and it sheds light on the fact that individual groups' inequity is shaped by their interactions with various levels of power. The goal of intersectionality within healthcare is to map health inequities and be more precise with how we address our patients and their needs. For healthcare providers, it's useful in basically tailoring a more suitable plan for our patient populations that we interact with. So just an example of intersectionality, I just picked this random individual. Her name is Sarah. She's a female. She's a single mother of 3. She's a high school graduate. She works part-time. She has mass health as an insurance. She lives with her aunt. She travels by the T. She's also Black, African American. So we see how these all create who Sarah is, but they also intersect. So some of what Sarah some of her challenges in life really have to do with the fact that she's African American and female. It may also have to do with the fact that she's a single mother and how people perceive her that way. And all of this intersectionality, we can't just look at as these isolated circles. This all makes up who Sarah is, and so we need to think about the multiple levels of what somebody brings and what their whole full picture looks like when we are addressing them, when we're interacting with them, and when we're providing care to them. So I also want to acknowledge that in healthcare, we also have a culture. We have an internal culture, and we have to think about how that internal culture intersects with the individuals who walk through the door. Here you see there's a doctor, right? We're just guessing by looking. There's a doctor, maybe there's an OR tech, maybe there's a nurse there. I don't know, but we do know that healthcare has culture itself. And so part of all the parts of healthcare culture that I could think of, there's plenty more, but we have insurance, doctors, nurses, material management, volunteers, patient care assistants, finance, administration, advanced clinicians, and we have to think about all the culture that exists within these external spheres and how they interact with the people who we're taking care of, and their own and those people's own intersectionality as well. So some of the barriers to cultural competence, we have barriers at institutional levels, community levels, provider levels, language levels, and we have to acknowledge that these barriers exist so we can work through them. And some of what I just talked about when looking at Black culture and Latino culture is that mistrust that's at the community level, but also at the institutional levels. So what is cultural competence? It's an attitude, it's knowledge and skills necessary to providing care to diverse populations. It's an ongoing process. I was just talking, I fashion myself as somebody who's culturally competent, but I'm also somebody who recognizes that really you can never be fully culturally competent. It's an evolving process. The example I'll give is in my department, we have a trans individual who works at the front desk, and I just was interested in knowing more about her and wasn't really sure how to engage in conversation with her. And so I basically mustered up enough courage to say to her, can I ask you a question? And she said, sure. And I said, can you tell me which pronoun you prefer me to use when addressing you? And she said, yeah, I'm female. I am full trans female. I am a she, you know? So, and from that conversation, I learned about her journey to becoming trans, a little bit about her personal life, and she actually volunteers at one of the hospitals here in Boston where she had her trans procedure done, and she walks individuals who are going through that process. She helps them walk through that process as well. So it was really cool because, again, like I said, I fashion myself as somebody who's culturally competent. I feel like I have my finger on the pulse. I wake up thinking about this stuff. I go to bed thinking about this stuff. But sometimes even I don't know what's the best way to approach somebody. And so sometimes it's just asking that simple question, knowing that you may be wrong. You may have to apologize for how you asked the question. You may have to apologize for what you've said, but being able to then move forward in that dialogue. Because it's going to be important for other dialogues that you have. So again, it includes having general knowledge of cultures as well as specific information, but not necessarily assuming that we know everything and being open to understanding new things. So how is cultural competence achieved? I really think we make this a lot more complicated than we have to. It's really about getting to know the person that you're taking care of and understanding that there is a lot of intersectionality. So I'll take myself for example. Actually, I'll take myself for example in 1 minute. You want to consider people's racial status first, I think. That's important, but you also want to think about their ethnic status followed by their cultural beliefs and their cultural practices. You want to avoid assuming that a person's race or ethnicity informs their cultural beliefs towards healthcare. There's a difference between first generation and then, immigrants and then first generation, second generation, third generation. I'll give you an example. In nursing school, we talk about if an Asian woman is giving birth, give her warm water. That's in a nursing textbook that I read. If she is an immigrant, maybe that might be a useful thing. If she's straight from Korea or Japan, maybe. But if she is the daughter or the granddaughter of an immigrant and she is in the middle of a push giving birth and you hand her some hot water, duck, because she may throw it in your face. She may, maybe. So we can, we read these things in books. We have to sort of backpedal in our deep dive in cultural competence in terms of what we're writing in our textbook for medical professionals or any individuals, and really take an examination of what our expectations are of people, which really should be, again, the first, consider your person, the individual, and who they are. The fourth is to be informed about your patient's cultural values and traits, and don't treat it as knowledge or fact. But use it to sort of inform your approach to them. The fifth is, as healthcare providers, be adaptable, always be open, and seek understanding. So I prescribe something, I have a patient who says, I'm absolutely not gonna take that. Why? Why are you not gonna take that? Explain to me why you're not gonna take that and what alternative you have. And they may end up saying, I have a tea at home that makes me feel better every time I have these migraine headaches. I don't want the Furacet that you've prescribed. And let's have that dialogue, and let me put that in a note in a way that the next provider can be sensitive to that. And then the sixth is to consider an individual's intersectionality and how it informs their own interaction with the healthcare systems. This is something that I think is a really very basic, easy thing for not just healthcare providers to use, but anybody to use. It's called the LEARN model. LEARN stands for listening with empathy and understanding patient and client's perceptions of the problem. Explain your perceptions of the problem, acknowledge and discuss the differences and the similarities, recommend a course of action or treatment, and be negotiable to an agreement.